So today we have Dr. Karen Anderson coming to us from Georgetown. We have Dr. Victor Sung coming from Alabama. We have Lisa Hale coming, well, she's from Vanderbilt, but she's coming in from Alaska and on her vacation doing this for us. So thank you, thank you. And then we have Terry Temkin, who was with UC Davis, but now coming at you from Washington, Gig Harbor area. So welcome all, and thank you all very much for coming on with us today. And if we could just start, a lot of people talk about a multidisciplinary clinic and why it's important to go to a multidisciplinary clinic. Well, it's because you get to see a huge team of experts that for symptoms of Huntington's disease, psychiatric and cognition and but also your PTs, your OTs, your support services that you need throughout the journey of living in a family impacted by HD. So I am going to start with Dr. Karen Anderson, and can you just tell us what you do and what role you would play in a multidisciplinary clinic?
Yes, thank you so much for having me here today. It's wonderful to be here and to see all of you this morning. Thanks to all of you for logging on so early in many places. So I am a psychiatrist, and my area of specialty is neuropsychiatrist, and that's care of psychiatric symptoms in people with neurological disease. My primary work is in the area of Huntington's disease, although I do see people with Parkinson's, Alzheimer's, frontotemporal dementia, and other conditions. But basically my role in the clinic is to address depression, anxiety, sleep disorders, substance abuse, irritability, aggression. So everything beyond the movement disorder that can come up in the course of HD. Often patients are referred to me initially with a question like, is this depression? And really it's a matter of teasing out, is it depression? Is it a motivation problem like apathy? It's wonderful to do this in a multidisciplinary clinic because having the neurologist like Dr. Sung right down the hall means that I can go right to them and ask them, is there a chance that this medication that I'm prescribing for a psychiatric symptom is going to impact the neurological symptoms adversely? We can discuss, is there a better choice that might work out so that the patient could get treatment for example, irritability and movements at the same time. So it saves a lot of back and forth having a psychiatrist and a neurologist able to talk to one another directly in the clinic. If you can imagine doing all of this through referrals and visits to different offices, it can take days and weeks for people to communicate with one another. So doing this in the context of a team is really important. The other area where I'm involved is in genetic testing. So when someone comes in for pre-symptomatic testing, if they're at risk and they want to find out if they have the HD expansion or not, I will do a psychiatric interview. And part of this is to decide, does somebody want to think about getting a therapist to support them through the testing process? I may talk with them about symptoms of insomnia, depression, or anxiety. Do we need to treat some of those before they proceed in the testing process to make sure that they're in the best spot when they get the results, whether they're positive or negative?
Yeah. Thank you so much. And it must be, you play a huge role because so many families say the most problematic symptoms are the psychiatric symptoms for families. And it's just lately that they've been really addressed and the families actually have a voice in that. So thank goodness for our psychiatrists that are able to help with those really hard symptoms. So Dr. Sung, can you tell us what role you play in the clinic?
Sure, thank you. I would echo what Dr. Anderson said. It's my good fortune to be here. I feel honored to be here. I'm a movement disorders neurologist by training. In that name, the biggest thing that I do is manage the normal movements. I would argue that I'm the least important person in my multidisciplinary clinic. My patients need a lot more of what the Lisas and the Terrys and the Dr. Andersons offer. But being honest, I think my managing the abnormal movement and the gait disorder part is a small part. I think my biggest role is captaining the ship, you know what I mean? Like coordinating what everyone else is recommending and taking the kind of ultimate responsibility for what is happening for our patients. So my team knows me as the one who brings all the harebrained ideas to the table for what we're going to do next with our clinic. But I feel like I'm constantly trying to bring more services to our patients and families and offer more and pack it into the same amount of time every time you guys come to clinic. But we do it all for you. So thank you guys for being here, and we're all privileged to be here. Thank you.
I know for a fact, I know many of your patients, and they would argue that you're probably one of the most important people in their lives. They all adore you, Dr. Sung, and that's because you're an amazing doctor for them. So now, Miss Lisa Hill, can you tell us the role you play at Vanderbilt?
Good morning, everyone. Thank you so very much for letting us be part of your Saturday morning. We're truly honored to be here. Social work is like the glue and the constant voice for you in our HD clinic. As has been spoken before, there are a lot of interdisciplinary team members in a clinic. You've got your neurologist, you've got your psychiatrist, you've got a neuropsychologist, you've got physical therapy, occupational therapy, speech therapy, nurses, nurse practitioners, dietitians, and the social worker is the constant contact that is your first person you speak with in the clinic. It's our role to shed a light and be the glue that connects all those disciplines I just spoke to. Often when you first come to our clinic, it's pretty terrifying to make that first phone call at 3 a.m. And it's our job as social workers to be with you through each step of that journey. From the very beginning, as Dr. Anderson talked about for genetic counseling, all the way to understanding what our clinic can do for you and to really help you be the very best you can be through each stage of that HD journey. So we're there to tell you where to park, tell you how to get to our very crazy blue room that's super small, all the way to sharing all the different research and opportunities you have to be part of studies, all the way to understanding what you need and how we can help you in your patient care. And most importantly, to provide you the best education possible, whether that be resources, whether that be disciplines within our clinic, whether that be research opportunities, and finally, one-on-one counseling. We are your people to help you understand each day and how you can be the very best in what you do every day. You are impacted by HD, but you are not HD. You are each individual, incredible human beings, and we want to help you thrive in every way that's physically possible. And in a nutshell, we're just really proud to be part of your journey. Thanks.
Thank you, Lisa. And I think one of our biggest challenges is Social Security and financials, and your social worker plays such a huge role in that partnership side by side with you. And then we have really great ones. It's really unfortunate how we don't have seasoned social workers in HD. So when we find these seasoned, really good social workers, we grab them and hold on, like Lisa and Lisa Hill, Lisa Mooney. We have these, I know I'm going to miss, so I'm not going to start naming them, but there's not enough. And I wish every Huntington's family had a social worker for their journey, because they truly are a huge help. So now we have, very lucky to have Terry Tumpkin. She is a nurse practitioner, and she worked at UC Davis caring for hundreds and hundreds of families. And we are very lucky to have her on Help for HD. So I'm going to let her tell about what, I don't know, we have 3 hours to say what role do you play in the clinic, Terry, over the years? Miss Terry Tumpkin.
I muted myself, forgot to unmute. Thanks, you guys. Katie, thank you. Lisa, that was just a wonderful synopsis, and thank you so much. And I think one of the things that came to me is that certainly when I was at UC Davis, it was like, as a nurse practitioner, kind of that glue too. And it's not that those two roles are the same or interchangeable even. Social workers are social workers and they do social work, and nurse practitioners are nurses, they do nursing stuff. I think one of the things that I've seen, Dr. Sung and I both are on the CPAC committee that reviews the Center of Excellence grants. I think one of the key components in terms of who that leadership position is, that person that is the entry, is, whether it's a nurse, whether it's a social worker, is having a dedicated Huntington's disease social worker or a dedicated Huntington's disease nurse or nurse practitioner. And that's rare. The centers that have those dedicated people, in other words, so if you have a nurse practitioner, a social worker whose time is 100% dedicated to that clinic, dedicated to managing things outside of the clinic, which is actually most of the work, right? You aren't in clinic all the time, you're in clinic usually weekly, but there's all the management of families outside of the time. And I know that, at least outside of clinic, I know Lisa spends an awful lot of time, as well as when I was at UC Davis, I spent a lot of time. We continue to advocate, those of us on this panel, we continue to advocate that where practical and feasible, that these centers where you get your care have those dedicated to HD only, for a couple of reasons. One is I think it's easier to team build, as everybody has said here, but it's also your time isn't diverted with managing other things, right? And so for many centers, it's a luxury. I don't want to mimic everything. Think, again, whether it is that glue piece is social work or nursing or whoever, creating access to families is paramount. It's absolutely paramount. We also encourage programs to have that single point of entry to a program, to a Huntington's program, to the team, not to the neurology helpline, right? Not to the hospital or clinic helpline. It's really the best case scenario. Some places can't do that, but again, we encourage everyone who can to do that. Have that point of entry to that person who is a clinic manager, managing what happens in your Huntington's disease program, and doing essentially the tasks patients need or families need, because as everyone knows, those calls often are frightening, they're anxiety provoking, and if you can get to that person who knows how to help you, all the better. So anyway, that was just like a little plug for those dedicated things. And it's just multitasking. I know Lisa, also Dr. Anderson and Dr. Sung, let me tell you, the physicians on these teams are not prima donnas. They'll get in, they roll up their sleeves, and they help with all this stuff too, because they're so dedicated to our community and to our families. And at the end of the day, that's what you do. It's not an assigned little task of things. It's like you do what you need to do to get the families what they need. So thanks for letting us say that, Katie.
Yes, thank you. And I have to say the first person that answered my phone, the phone for me was Terry. So she changed my life. So she picked up the phone when I called. So there's that. I think the most important thing is picking up the phone and being there. And Terry taught me that for sure. So now let's go into the questions. These are questions that were submitted by you, the community. When we put out what questions would you have for a panel of experts. This is what we got this time. We can't answer all of them submitted, sorry, but we do have 20. So let's start 20 questions with Help for HD. And we will start the panel with Dr. Victor Sung. Should I start palliative care early on? What are the benefits? My husband is in mid stages and I think about this often. He also likes his medical team. I have heard once hospice and palliative care is brought in, they can't see their team anymore because Medicare only pays for one. Is this true?
That's a great question. I think the first thing to break, it's three questions rolled into one, but to break it down a little bit, first, I think the thing is that don't forget that hospice and palliative care are separate, often can go together, but don't have to go together. And you can involve one or the other or both or neither. And some of the particular differences are that palliative care doesn't have to be end stage. They can help to palliate or make better a particular symptom or a particular set of symptoms. So getting palliative care physicians involved, they're usually a team led by a clinician. You can get palliative care involved at any point if there are symptoms that you need them to help to get better. Hospice is a little bit different in that medical certification for hospice requires that we certify that you have your loved one has a progressive disease that has no cure and may reasonably be within the last 6 months of their lifespan with that disease. So in mid-stage HD, probably a little too early to get hospice involved. But again, even though we say that they might be within the last 6 months of the disease, you don't have to wait until the end to get hospice involved either. I often think about hospice when we have late stage HD as an extra resource to get more help for families at home. I've had many patients who go on hospice, they exceed their 6 months that we said might be in late stage HD, who knows, it might be 6 months, it might be more. They exceed the 6 months, they come off of hospice, we do some things, and then they go back on hospice. And I've had multiple HD patients go on and off hospice multiple times during their late stage, but usually we reserve hospice for late stage HD. The question particularly about can you not see their care team anymore? Palliative care is just another set of clinicians that can come alongside. So if you involve palliative care, you certainly can still see your care team. Hospice is a sometimes yes, sometimes no thing. But as you can imply, or as can be implied by my previous answer, I've certainly continued to be involved with my patients' care, even if they go on hospice. One of the things is they don't like you to have continued aggressive treatments. So aggressive titration of, say, Austedo or something like that, they're not going to want when you're on hospice. But preserving things how they are, or continuing the medications that you're already on, and continuing an interaction with your care team usually is still allowable. So hopefully that answered the question. Thank you.
Really did. Yeah.
And if anyone has anything to add in and work in, if you think of anything, please do that. And then I also forgot to say, this is a very long session. So if any of our panelists have to go grab more coffee or water, you just unshare your screen and we'll come back on track.
Awesome. Okay. So the next question is for Terry Temkin. Hi, Terry. Good morning. I need to gain weight, but I'm struggling with healthy calorie intake. I've asked in groups, I'm assuming these are online groups, and I typically get, don't worry about healthy calories, but I am. Any suggestions?
Thanks again. We probably will all be saying thank you for sharing the question, for asking the question. And this is another one where my colleagues on the call may have some good ideas too, right? I think probably the way to start that answer is looking at why you lose weight, right? Why this is such a struggle for you. And some of it is probably, and I totally hear this thing, oh, I don't want to eat a bunch of fat and sugar and whatever. I understand why you're saying that. There's probably a preset in terms of what your body is and what your body size is that, is determined. We also know that there's a metabolic burning in some people with Huntington's disease. We call it like your engine just burns hotter. And that's why you may need extraordinary calories, like 5,000 to 6,000 calories a day, just to maintain your body weight because of that furnace is burning hotter. Some people, you don't say, some people have swallowing difficulties, which makes getting enough calories in challenging. They just can't, it's a challenge to eat, challenge to swallow. And so eating can be fatiguing, it can wear out. And so I think thinking through what may be applicable to you in terms of calorie intake, out the gate, I think probably one of the best things to do, if you have access to one of the centers of excellence, this is a no-brainer for them. If you don't have access, and we know a lot of people don't, your primary care physician or who you, or your care should help you do this, is get a dietary consult. Those people specialize in helping people with maintaining their caloric intake of what they need. It will have a lot of helpful information. You may be somebody who also needs to see a speech therapist for a swallowing evaluation. That may be a helpful interchange or a helpful referral, but a dietary consult for sure. I think one of the things that I've counseled people over the years is try to eat more frequently. We're so programmed, we eat breakfast, lunch, and dinner. But again, if you are having swallowing challenges and you might not be able to get enough calories in 3 times a day, some people, this was a trick one of the families that I worked with told me, and I thought this was so golden. But things like milkshakes, you may not want the fat in ice cream. I get that. You could use low-fat yogurt and make things with fresh fruit and low-fat yogurt, just adding more calories and doing that a couple times a day. So you could pick up 300 to 400 calories, add some peanut butter if you like that taste. So there are things where you don't have to go outside the dietary restrictions you have for a healthy diet, but just eat more and eat more frequently. That little trick that the parent who was the care partner for this particular family, her son loved milkshakes, just loved. And she got so tired of making milkshakes. she just burned out on it because she was giving him like a couple a day in addition to all the other meals. So she used to drive through some of the drive-through restaurants like McDonald's, Wendy's, whatever. She'd pick up like 10 of those like Frosties and shakes and whatever they individually make. And she'd put them in the freezer. And then when he got the urge, he could just go into the freezer, set it on the counter, let it defrost a little, and it was there. And I thought the strategy of that was, first of all, they weren't as concerned about the healthy choice kind of thing. So that kind of thing worked for them. But I think one of the take-home message to me was having it pre-prepared, right? Whether you make your own, you could make a number of healthy shakes, put protein in it, use a high quality protein drink to mix with yogurt. And you could just pre-do those and stick them in the freezer, and then you're not consumed with meal preparation all the time. But clearly, dietary consult, eating more frequently, and eating as you can, eating more of the things that you choose to eat. I'll have to tell you, a diet of salad and carrots isn't going to make you gain weight. So that dietary consult will be really helpful. So do you guys have anything else you want to add to that?
I would add to think about what you're drinking. So if you're drinking Diet Coke all day long, that's probably not going to help you put on weight. It's going to fill you up, but not with anything useful. So think about drinking either fruit nectars or other things that are healthier, if that's what you like. If you're not so concerned about health, think about drinking maybe some soda that has sugar in it. And I'm wondering, Terry, what's your thought on things like Ensure, about buying the dietary supplement drinks?
I think that works perfectly. To me, it's like personal preference. I think those things are good calorie adders. I think they work well. You hear so many complaints about it tastes like, ugh. And what I would encourage people to get around that, if they don't like the taste thing, mix it with ice cream, mix it with yogurt. You can mix it with, make a smoothie out of it instead of just drinking it but like that preparation, Dr. Anderson, I think is key, because we also, as you well know, and as well all of us know, that sometimes that initiative to do meal preparation, that initiative to do that may be a step that's hard for someone to take. And so whether you can do it or not, but I totally think those strategies and there's so many more. When we first started in this game, Ensure was it. But there are tons of athletic high protein powders and supplemental things on the market now in Costco that are relatively inexpensive and can be used. And I think a good source, especially for that supplementation between meals. Good point. Thank you.
And just very quickly, the only point I wanted to add is the only reason why we ever recommend unhealthy calories at all is convenience. Obviously, if we could get the calories that you need with healthy calories, that's optimal. To get the calories that you need, it's a huge pile of boiled chicken, right? If you wanted to do that. And then it's so much food and you feel full and bloated all the time. And so it's balancing that. Obviously, eating smaller meals more often, as Terry said, would be great. But then sometimes people feel like they're eating all the time and it's too cumbersome. So I think it's all in balance. If you do all healthy calories only, it's just a massive amount of food and you have to balance that. So that's the only thing that I would say.
You guys, Katie, I'm so sorry. I know you may be trying to move the other thing, but one other thing, I'm pretty sure probably in our listening community here, somebody would have this question about the use of cannabis and weight gain. It's pretty hard to get your medical team on board. I have to tell you, many years ago, we would try that. Me personally, in terms of helping patients navigate that, we didn't have a whole lot of luck with that. I don't know if that's Huntington specific, because of something with what's going on with their HD just makes it even more challenging. I know lots and lots of former patients and things like that who supplement that way. And personally, no judgment. If you think that cannabis use would help you gain weight, I think you got to do what you got to do, right?
Thank you. Thank you so much, Terry. Our next question is for Dr. Anderson. My loved one is dealing with a lack of interest, is considered cognitive or psychiatric. There seems to be some confusion, and I'm wondering if it was better defined, would there be more studies or treatments for apathy?
Yes, so there is a lot of confusion on this. Apathy is one of the most common things that I'm asked about in clinic, often not directly, but families will come in and describe what's going on at home that's troubling them. Often it's the family who brings it up, not the patient, because people who have apathy, which is a lack of motivation, a difficulty getting started on things, often do not complain very much about it. Sometimes they will. My favorite apathy story is when I trained at Columbia, I had a patient who was a cab driver and developed early HD. And he said that he knew there was something wrong because he was always the guy, if someone cut him off in traffic, he'd have a baseball bat in his backseat and he'd get out and start smashing their car. And he's lost his interest in doing that. He just didn't have that aggressive drive anymore, which is probably better for everybody. But that's sort of an extreme example. But often patients will say they aren't as interested in things, but it doesn't seem to bother them. But families obviously are very troubled by the feeling that, that loved ones aren't engaged and won't help out with things around the house or can't seem to follow through on things. It is a mixture of psychiatric and cognitive. Part of it is the initiative of planning a task, going through the steps of a task, which is more cognitive. Part of it is being engaged, being interested in others, and the reward that you get from doing that, which is more psychiatric. So it's a mix of the two. I think that's part of why research on apathy is so hard, because it kind of falls between the cracks of psychiatry and neuropsychology and cognitive science. There are not terrific treatments for apathy. So in my list of things for all of our sponsors who are listening, apathy is one of the big ones. If any of you have an interest in working on behavioral symptoms, apathy is one of the big ones where we really do not have terrific treatments. When someone comes in and the family tells me about lack of motivation, lack of drive, lack of interest in others, one of the first things I will do is an assessment for depression, because apathy can be a big part of depression. Someone who's withdrawn, sad, complains that they feel like nothing in life is worth living, for example, that can be apathy with depression. And in that case, sometimes if you treat the depression, the apathy will get better. But we all know that in HD, many people have apathy that is not depression. Apathy is one of the most common psychiatric symptoms. It tends to progress. So once someone has apathy, it will get worse throughout the disease. And it's true, there has not been a lot of great work on apathy. There was one clinical trial in Europe looking at bupropion, which is Wellbutrin, an antidepressant drug, that actually showed that Wellbutrin did not help apathy, but it did help depression. So it is a very good antidepressant, which we know already. So in terms of how we might treat apathy, my first step is to look at the medications that the patient's taking. This is where I might walk down the hall and talk to Dr. Sung and say, it's great that you're treating chorea, but maybe you've overdone it a little bit. Could we back off a little bit on the anti-chorea medicine and see if maybe this person has a little more interest in things? I might talk with our social worker and say, hey, Lisa, is this a case where the person needs more activity? Is there a good day program around that we could somehow get this person into? Or could we get a companion in the house so that there's more structure and more going on? I might review their medications. Sometimes antidepressants, especially the SSRI antidepressants, can make apathy worse. So I might reduce some of the medications that I'm prescribing. And then sometimes I would think about a more activating antidepressant like bupropion, although I have to say that my success with treating apathy is not tremendous. I'm sure all of you have thoughts about apathy, the rest of you also.
You find sometimes that it's like a family thing, because you were saying it doesn't bother the patient as much. It bothers the caregivers. Is there something where, do you guys find a lot of times you have to talk to the caregivers? It's pick your battles, and sometimes it's maybe a symptom that we have to accept. Obviously not 100%, but it is one of those symptoms I think a caregiver has to learn how to live with.
Yes, I think there's a part of learning how to live with it. There are some behavioral interventions that can be pretty helpful, and our social workers often will help with those in terms of structuring activities, presenting things as yes or no. So not what do you want for dinner, but do you want chicken or pizza? doing activities with people. So you can't just put a basket of laundry in front of someone and say, put this away, fold it, but sitting with them and helping them to fold it, helping them to put it away, which of course takes twice as long and is not as efficient, but it does engage the person in something. And then figuring out, are there things that somebody might enjoy participating in? So if you don't have the initiative to go out and fish, but maybe you like to watch fishing shows on TV, things like this. So whatever you can do to bring the person in a little bit, and then certainly helping the family to understand that an apathetic person usually is not suffering themselves. They have lost their motivation and drive. They may not care so much that they're not going out and doing the gardening and things like that. They may not get so much enjoyment out of it.
Thank you so much.
Thank you. Next up is for Dr. Sung. What are the first signs that you see in people with HD that are having troubles swallowing? What can be done to help?
I think there's a lot of early signs. If you just Google early signs of difficulty swallowing, there's a number that you'll find. I think the ones that I pick up on the most are going to be coughing while eating, or residual food in the mouth or around the mouth after eating. So those are the two things that I look for the most. Or obviously actual mini choking, things like that. But I think if you're talking about, you don't notice any clear choking, but just a little coughing, clearing throat while eating, and then cheeking or residual food in the mouth or around the mouth. What can be done to help to try to prevent getting to the point where we're having overt swallowing stuff down the wrong pipe? I would say for liquid, I think about things as like difficulty with swallowing liquids and difficulty with swallowing solids, and separate those. For liquids, I don't advocate for thickening the consistency of the liquid until it is medically recommended by the speech therapist, and there's no other route of action, because most liquids, when you thicken them, become really disgusting, and then your loved one isn't going to want to take it, and then they'll become dehydrated, and it's a bigger problem. But for regular liquids, taking it out of a straw, a cup with a lid and a straw in it, it will moderate the amount of liquid that goes in the back of the mouth at one time. So you can't, because if you've been around your lovely patients who try to eat and drink, they have what I call a shoveling phenomenon. Like when they drink, they tend to take huge gulps of drinks at one time, and they're coughing and choking. Or when they eat, they shovel all the food in their mouth all at one time. So for drinking, a straw will kind of meter the amount of liquid back at one time. And then with food, cutting it up in small amounts, and then only putting certain amounts of food out at a time. Yes, it's more cumbersome to you, but it prevents them from shoveling all the food. Even if they took everything on the plate, it's only a small amount, and then you put more, and then you put more on there, and portioning it in that way can help. If you find that dry solids get stuck very easily, then moistening them with gravies, sauces, ketchup, whatever, things like that to help the solids go down can be helpful. I have one HD patient, when he has a meal, he has 1 cup that he drinks out of, and he has 1 cup of water that he dips his food in. So to kind of moisten it to help it go down. And then, as we talked about at the beginning, get thee to a multidisciplinary clinic and have an evaluation with a speech therapist. And they can really help with, they don't do formal necessarily swallowing tests in the clinic, but we'll do simple swallowing tests, and then can give you a lot of recommendations on things to take home that are specifically adapted for your loved one. So those are the things that I would say.
Thank you, Victor, for saying coughing too, because I know the couple of our friends will talk about, my loved one doesn't choke, but they cough all the time. So a lot of times we don't equate choking, choking, not coughing. But that is a problem in the beginning, you think, is more coughing in the beginning.
Yeah. Okay. So
Yeah.
while we're having some technical difficulties, I think Lisa dropped for a moment. So we're just going to skip over her questions as you guys have, and then we'll get back to hers when she comes back on. And so we're going to go to Dr. Sung again. My child who has HD will only urinate outside. I don't understand why he goes to the backyard to urinate instead of just going to the bathroom that is closer. I am worried about someone seeing him and charging him with exposure. How do I stop this behavior?
Yeah, I think this is a complicated question. And my first thought when I saw this question was to ask my wife, who's a psychiatrist. So I'd love to get Dr. Anderson's take on this as well. I think toileting behaviors, normal toileting behaviors are often, not always, but often ways for the HD patient to try to regain control when they feel loss of control that this disease is robbing them of, and can't, just a way for them to express it because they can't express it in another way. And I think a simple thing, not all of this needs to be medicated. I think non-medical approaches are better first, is just to think about this like potty training. When you first potty trained them as a child, the kinds of things that you do to potty train them are, all of us that have children have had to do. I call it bribery, but also the medical term is positive reinforcement. Like you could do things like, hey, how about if you can go all day without urinating outside and urinating in the toilet in the house, then you can get this prize, or something like that. And maybe nighttime is not to try to get rid of it altogether all at once. It may be difficult, but to address your issue about public indecent exposure kinds of things, maybe try to get rid of it during the day first, but they can still go outside and at night to use the bathroom outside or something like that, moderating it that way. Psychologists or other therapists have behavior plans or cognitive behavioral therapy, depending on what level of cognitive work your loved one is able to put in, or what the age of the child is. But a lot of therapists are experienced in coming up with behavior plans to try to intervene for problem behaviors. But that would be my take on it. I'd love to hear Dr. Anderson's as well.
I think those are terrific points. And I absolutely agree with not trying to medicate something like this, because I don't think that will work. I think if your backyard lends itself to this, if there's some way to set up a privacy hedge or just like a wicker screen or something and allow it, or at least allow it at certain times of day, then that could be an option depending on where you live and how your backyard is set up, because I am a fan of not picking your battles. And then I guess it also depends on how well your neighbors, right? And if they're understanding and charitable people, can you have a conversation with them and ask them what they're able to see and what they're not able to see, and try to work something out with them? So I would definitely be in favor of all of the behavioral approaches and of trying to gradually change it, gradually move it in the house if possible.
I just thought of, I don't know if you guys are backpackers or campers. They make those, I wonder if you could make it not to reinforce it, but in that interim time when you're trying to move away from it, you get one of those little backpack. They have those they're just tiny little tents, right? They're there to do your business tents. And if you might be able to put one of those up and potentially guide them and make it not a reward, but create some privacy, but use one of those as some kind of incentive for reinforcing the privacy part.
Yeah.
That's a great idea. And we actually know 3 families that they're boys and they only will urinate outside. And a big thing is the smell. We do have a good friend of ours that I know she would not mind us telling you that what she found was baking soda. So if you are dealing with this problem of your loved one only urinating outside, and that's their behavior, the smell, she said she just sprinkles baking powder everywhere and lets it seep in, and the smell has gotten better out in her backyard. I thought that's a good caregiver tip.
And I think part of it is the not giving it attention, right? So if it's possible to ignore it and just sprinkle baking soda, that's an option. That's why I'm a fan of just putting up some hedges and ignoring it if you can, because the more you emphasize it, the more you may be rewarding it and giving somebody attention for something you don't want them to do.
Thank you so much. So Lisa, you're back. We're going to head to you. So I am new to Huntington's and I just found out I am at risk. What do you find is the hardest loss that people with HD face, and the thing they have struggled with the most?
I first really want to thank the person and their courage to ask this question. This is what I affectionately call a 3 o'clock in the morning question that kind of burns in your heart and soul. I think, and again, I definitely want everyone else on the panel to chime in, but I think loss of choice and loss of independence are 2 really big fears that are part of this initial, oh my God, what's happening? And I want to flip it, and I want to say that you are the same person that you were before you found out you're at risk, right? All of us have 2 copies of chromosome number 4, that Huntington gene. And I think in our clinic, our way of thinking about it is we want to give you the best choice possible and the best education possible to make your journey the very best that it can possibly be, whether you choose to test, whether you choose not to test. So I want to emphasize here, regardless of the things that your family's experienced in the past, and maybe some of those ghosties that you're dealing with as you go through your journey, you have an incredible support system here and an incredible HD support team globally that can help you have choice, help you create that plan that's yours for you and your family. We are all part of 55 HD centers of excellence, right? And then there's another whole cadre of advocacy organizations. And I really emphasize and advocate for you to become aware, become educated, answer all those questions. And long before you want to come into a clinic or even approach a clinic, there's tools out there that we're going to give you on social media so that you can truly learn and grow in the education of HD long before you make that first phone call. And while you're waiting for your appointment or waiting to make that call, there's support for everyone, right? You can go to hdsa.org and learn about all the resources, learn about what other people have experienced, okay? Also too, Help for HD, tons of brochures, tons of material, tons of ways for you to start your journey in a way that's for you. Obviously, the podcast is a fantastic way as we're sharing our stories today, but if everybody learns in a different way, right? So if you want to read about something rather than having it in a podcast, you can go to HD Buzz. HD Buzz is an absolutely magical way for you to understand all the different research opportunities there are in plain language that you can understand, right? Another way to become involved is to be part of HD Enroll. It's a longitudinal study. It is the largest platform for families and clinicians and researchers. You can come into a clinic setting, you can see what the vibe is and what you're comfortable with. And if that's a place that you want to start your clinic with, okay? If you're a young adult, I highly recommend the HDYO website. There are incredible videos, reading, ways for you to see how other peers have handled really tough questions. How do I talk to my friends about HD? How do I begin to date? How do I start a family? All those types of things. Also, too, there's a wonderful person named London Tabor that if you're understanding or learning about juvenile HD, you can go and work with her and she can give you access to a juvenile HD support group that is a safe place. And I think it's a very personal process. There's no one way to gain information, but there's tons of avenues and resources out there. Also to call your local HD clinic and ask to talk with a social worker. And no question is a bad question, right? If you don't want to talk to us, get our email, chat with us, and we'll put you in contact with the format and the platform that you feel comfortable with. The journey that you have doesn't need to be what others in your family has had. You don't need to have those negative experiences. We are all here to support you in the endeavors you want to do and the things that you want to do. As a wonderful neurologist on our team says, let us take your fear. Let us take your ghosties at 3 a.m. Let us take care of that so that you can live the very best life that you possibly can.
You. Thank you for all that, Lisa. And I'll let everyone, if you guys want it, because this is a question I think everyone could, this is, what is the hardest thing? What is going to be my hardest part of my journey here for someone who's new? But all the links that Lisa just said on Help for HD, Facebook, and all of us watching on the social media lines, all those have been listed. Lisa gave us all the links. And so those are all available for you guys just to push.
Katie, thanks for saying that. And Lisa, I was just going to follow up to probably loss is individual for everybody, depending upon where they're coming from, what their family circumstances are, how they've learned they're at risk, what those situations are. But I think one of the things that always strikes me about the loss question is whether your gene status or not, having to now learning that you're going to be facing an HD journey, it really robs you of any security that your future may be, what you envisioned it to be, right? It's the loss of that security that things will be okay. Because if you're at risk and you don't know your gene status, you worry probably every single day whether you inherited that gene or not. And if you are at risk and you've tested and you are gene negative, you know, that's celebratory, certainly, but then your concern is about what about your family, the family member and other people. And then if you gene test and you're positive, of course, then that anxiety is transferred into, oh my gosh, what happened to my life? How do I navigate now? When is this going to happen? I just dropped something. So to me, what people lose is that security of just assuming your life is going to be fine and everything's okay, because I think we're kind of programmed to start out that way. And HD takes that away. And to me, that's a huge loss, that loss of security, that your body's not going to fail, that your mind is not going to fail. It's a big loss. So I'm just going to share that.
Does anyone else have anything to add, Dr. Sung or Dr. Anderson? So, Dr. Anderson, you're up. I am on so many medications that are treatments of symptoms. I'm on Austedo for my movements. I am on Wellbutrin for my depression. I am on insulin for my diabetes, but there is nothing for me that can help with my sharpness. I slowly feel my cognition slipping away. Are there any medications to help specifically with the way my brain is slowing down? Even if it isn't for people with HD, I am open to trying anything that will help.
So this is a really common question. Unfortunately, there aren't any approved medications to treat the cognitive issues in HD. So the slowness of processing, the difficulty with organizing thinking, the difficulty with planning and getting through steps of things. And then as the disease progresses, difficulty with remembering and recalling information and using it. As I mentioned before, when I was talking about apathy, some of the same things apply to the cognitive symptoms in terms of reviewing all the medications. So that's one of the first things I do with a patient who has cognitive complaints, reviewing all the medications, minimizing the medications that might be impacting cognition in a bad way, possibly increasing something like Wellbutrin or bupropion, which is an activating antidepressant. Sometimes that will help people to feel a little more alert or a little sharper. There's some off-label use of medications that were approved for Alzheimer's disease. So there are medicines called cholinesterase inhibitors. Aricept or donepezil is probably the most widely recognized one of those, most widely used. Some people will try those off-label. I'm not terribly impressed with the effect of those, but it's something that if someone wants to try something for cognition, I think that is available. I encourage a lot of non-medication interventions as you're able to, getting outside and actually getting into the sunlight and the fresh air, because I know a lot of people stay indoors a lot, especially this time of year, but trying to get outside and get sunlight exposure, and then getting a little bit of safe exercise every day. So if you're able to walk a bit, maybe walk with a companion. The studies in normal aging are very clear that people who do a little bit of walking every day or a little bit of some kind of aerobic activity do better in terms of cognition than the people who don't. So we should all be doing this anyhow. If you're not able to walk safely, maybe having little hand weights and doing hand weight exercises, or sitting in a chair but stepping in place, or maybe having a seated exercise program that you do with a companion or with a video so that you can do it safely without falling. I think those are all things that can help you to attain your cognition. And then having contact with other people, trying to do things that are intellectually stimulating. So rather than watching television, reading a book, or listening to a book on tape if you're able to. So I think those interventions can be very helpful for some people. I think that especially if you're at home and you're by yourself all day, the boredom and the lack of stimulation can sometimes make you feel more impaired than you are. I will say that I'm very happy to see SAGE as one of our sponsors today, because they are doing a study on treatment of cognitive symptoms. So it's a research study. It's not an approved medication, but it's wonderful to have a sponsor that's taken an interest in cognitive symptoms. Anybody else have thoughts on this?
So we'll go to the next one. So for Dr. Sun, I was recently told I should not test for my own gene status because I have depression. I left the clinic feeling like I wasn't in charge of my own medical decisions. I am not suicidal or anything close. I just don't have a huge support system. I was basically told to try again later. How can I avoid being treated like this when it pertains to my own genetic future? And how can I get tested?
Yeah, wow. I think my first reaction when I read that question was just, oh, I'm so sorry. That's devastating. And I fully understand how devastating that must have felt when someone told you that. That's unusual. I don't know all that went into it. I mean, certainly all of us on here have done predictive testing for HD many times, and certainly not in my clinic or any of our clinics, I'm sure, is just having depression a reason to stop someone from testing. So I don't know how, without talking to whoever your clinicians were, what their thought processes were. I'd be surprised if it was just having depression alone, but maybe some part of it was what they perceived about your lack of a support system. To avoid this, if you don't have a support system, some of it is practical, like you live in a family with HD and you may have lost loved ones close to you to HD, so that just makes your support system smaller. You can use your clinical team, you can use sources like this virtual forum. There's a huge community out there to be a support system for you. Maybe find through support groups other people who will be support systems for you, or things like that. There are ways to use your clinical team or digital connectivity and our increasing connectedness with social media to have a support team. As far as how can you get tested, I still would advocate for going to a center of excellence and doing the full process with genetic counseling and social work support and things like that, to do it the right way so that you will be supported through the testing process and afterwards. But how to do it, the things that you can do to prepare yourself is maybe to address these concerns ahead of time. So work on building up a support network for you before you ask for testing again. If the depression is a concern, have a plan of action in place and ongoing for the depression, so that if you're assessed again, okay, I know I have depression, but here are the things that I'm doing to address that proactively. Take advantage of resources that are out there. HDSA offers through from a generous grant from Teva, free telehealth counseling through the Amwell platform, and you'll get connected to a counselor who has been trained specifically in HD, and it's completely free. So take advantage of that and say, oh, I'm meeting with a counselor on via telehealth to address my depression, in those ways, just to show that you're ready. And then how can you get tested? It may need to be, if you don't feel comfortable with the team that you initially approached, you might need to find another center of excellence. But there are many out there, as Lisa said. With partner sites, we're up to 60 centers of excellence across the United States. So you might be able to find somewhere closer to you, but find another center that's not too geographically distant. But a difficult situation. Hopefully those things provided some help on things that you can do.
It's so interesting because I know the whole testing thing with HD is it's so confusing to me, because my brother has cystic fibrosis. The test seemed pretty straightforward. He got diagnosed with cystic fibrosis. We've heard stories about people taking the step, putting the blood, drawing the blood, and then the blood being thrown away by the lab. This has happened to families. Like, we hear horror stories from families when it comes to testing. And it is such a huge, everyone talks about, it's such a huge step to be tested for HD of the family. Yeah, it is. And so when we hit glitches, it rocks us even more. So it's really frustrating. Is there something wrong with testing, or is it maybe they're like, Terry, getting like, when you get cancer diagnosis, right? Did you have blood thrown out? Did you have people tell you, I'm not going to let you, how is getting, diagnosed for cancer? Was it as hard as with HD?
Thanks, Katie. Thanks for bringing that up. No, I don't think it's the same. It's hard to hear you have anything, right? Whether it's cancer, Huntington's, or whatever. And I think probably sometimes it may be a little more hopeful because there are so many treatments for cancer, and all we have is symptomatic treatment for Huntington's. So I never would put my diagnosis at the same level of Huntington's at all. And I don't mind disclosing that. I think I'm going to bring up this word because all of us on this panel are familiar with it. I think over the years, there's been kind of accusations that the centers, the clinicians, the counselors and stuff like that are paternalistic about that information. And I think we need to put it out there and we need to talk about it. And on an individual basis, I think that no, families have run into that paternalistic attitude that I know better than you do what is best for you. I think it exists. And I think that even makes families feel even worse, because as you've said, everybody on this panel has said multiple times, it's about empowering families to make the decisions that are best for themselves. And even if I may not personally agree or professionally agree about somebody's fitness to test, it actually isn't my decision. Now, I would have a role as a professional of giving my advice, but at the end of the day, we really are trying to empower people to make the decision that's best for them. I know that lots of people don't get seen at centers. I know that, and I keep coming back to that because we keep throwing centers out there. But HDSA went through a number of years ago and rewrote genetic testing guidelines that centers are now, that they're required to use those testing guidelines to be a center. So I know there are efforts within the medical community to try to dispel that paternalism. And I think what Dr. Sung said is totally right on. If you have a loss of faith in that treatment team, if you feel like you don't trust them, you go someplace else. And I think one of the things to start with this person who had this situation is call a genetic counselor and talk to them about this. I know that, I'm sure Vanderbilt feels this, I know that all of us who operate centers, we operate centers without walls. In other words, you don't have to be our patient to talk to us. You can talk to us. call another center, ask to speak to them. You probably have to set up an appointment. They might not be right there and answering the phone for you, but the people like Lisa and other people who create access to that center can help you get to that person and share your thoughts and experience with a genetic counselor that's totally unrelated to this situation, and try to come up with a strategy for approaching this. Again, I wouldn't give it up. I wouldn't feel discouraged. The other thing is also reach out to somebody to take a look at, are there mental health issues that you could and should be treating? But I'm sorry you had a bad experience. As Katie points out, you're not the only one. And internally, we all struggle to make it better for you guys and make it as accessible. You got anybody else want to jump in there?
Yeah, I would say that my philosophy on testing has certainly evolved. When I first started working with people doing at-risk testing some 20 years ago, the philosophy in general was talking people out of testing, being very persistent about, why would you want to do this? This is just not the best thing, which I think is very paternalistic. And I think we've all evolved a lot away from that. I would say, as I said in my introductory statement about the role of a psychiatrist, that if someone has depression, I would never make that a stop sign on the road to testing, but I would say, let's slow things down a little bit and treat the depression, maybe look at access for a therapist. So I do wonder why it's being presented to this person as a no on testing, as opposed to what I think is a reasonable thing. Maybe you want to slow this down a little bit and get your depression treated so you're in the best possible spot to get the results, whether they're positive or negative. But I'm also very sorry that it's being presented this way, because that's not helpful. And it's not helpful in getting your depression treated if that is an issue. Lisa, I'm sorry, I jumped right before you.
No, you're totally fine. I'm going to tag on to what Terry said earlier. We work as a team across the United States. We often will call and say, because we'd like to say families all live in one state, but they don't. They're all throughout the United States and North America and Canada. So you can call us at any point in time and say, help me understand what I need to do and what my next steps are. First of all these conversations will be confidential. You can share with us what I affectionately call the good, the bad, and the ugly. And then we're going to call the center that's closest to you in your area and say, this person has had a really negative experience and they're terrified. We don't want you to go back into your isolation. We want you to come to the table and say, this sucks. And I'm going to be super honest. We've all heard these stories, every single one of us. And it's our job as centers of excellence to educate the community, to say, please respect and empower people to make the choice that works for them. We affectionately say in our clinic, we're never going to tell you what to do. We're never going to tell you how you feel. We don't walk in your shoes every day. We will walk beside you and we will give you all the information, probably too much. And then we'll help you to make the best decision for you, not friends, not family members that might know everything, but for you, so that you can go forward with that information in the best way possible. So we know you're vulnerable. We know you're scared and you're really frustrated. And we'll work with you through all those phases and get you to the right spot. And you know what? In our world, you can come and talk with us 2 or 3 times and say, you know what, I'm not ready. And then that one day when you do come in and you're like, okay, my heart and soul says it's time to test, then we will work with you to get you in as quickly as possible. Thank you.
Yeah, I just want to add really quickly. I love Terry's comment about centers without walls. Just from what it reminded me, I had a patient who lived close to where Terry lives and had a negative experience with testing, but she had a loved one who lived in Alabama, and we worked it out so that we coordinated her testing when she was visiting her loved one in Alabama with us, even though she lived in Washington, Western Washington. I had a patient whose daughter lived in New York City and was considering testing and couldn't get to it. And so I was in New York City for a meeting for HD, and we met for coffee and talked about testing at Starbucks. And so we will do that, and there, like, geographic boundaries, we can overcome that. But just know that as a community, we're here for you. I feel like if you get yourself to the point of wanting testing and are ready for testing, then we need to do everything in our power as a community to support you through that process and make the barriers as low as possible. So.
Thank you for that, Dr. Sun. Lisa, are there any programs for terminally ill individuals that help provide modifications to a home that is not ADA friendly? We are middle income range, not a service family, and own a small home, nothing else. We don't have any savings.
Awesome question. Step number one, work with your healthcare provider or your center of excellence social worker, and you're going to ask for a home health assessment. And what that's going to do, the neurologist will go ahead and put an order into the system. And basically, you will have experts come into the home and truly see what your home needs. Do you need to rearrange all those really nice freestanding rugs? Do you need shower chairs? Do you need rails in the bath? Do you need a raised toilet? All those things that make your life easier. And once that happens, there's this great order called a durable medical equipment order, or a DME order. And basically that will allow your insurance company to pay for those things that need to be put into your home. Secondly, there's an incredible website that I did find throughout this week. It's called www.211. And that, guys, is a nationwide United Way access. And what that allows you to do is connect you to an expert that will, in your community, that it's maybe you need a ramp in your front door. Maybe you need something that allows you to have access to a different part of your home that maybe an order cannot access for you. And this will connect you with experts in the community that can help you do that. And then finally, put your social worker to work. If you need something that I haven't talked about, talk to your social worker. We have access to grants and funds that can help you and your family move about your home with safety and grace. Because that's your space. That's where you feel the most comfortable. And it's our job to make sure that you stay in that home as long as possible, being able to do all the things with as much independence as you need. Awesome question. Thank you.
Thank you. For Terry, how can I help my wife continue to feel that she has a purpose? She is limited physically, and I know she has been somewhat withdrawn. She used to do everything for her children, and she is unable to now.
I hope who submitted this question is able to be on the call or able to be on this platform this morning, because this is actually a really good question, and they all are really good questions, but sometimes we don't ask this. And so I really appreciate that somebody asked this. You know, I think it somewhat goes back to our comments about loss a little bit, right? Because I'm pretty sure that your wife is aware of and has been experiencing the loss of what her familiar roles were as she was more physically able, as her symptoms weren't preventing her from doing the things that she normally is doing. So I think one of the things to think about is, in that question was also, I know she's been somewhat withdrawn. I would try to plumb that a little. So is the withdrawn because, and reach out to one of these Centers Without Walls, right? Or your friends, or let me tell you, your Huntington's community through portals like Help for HD, your HD community, man, I'm telling you, they are a huge wealth of information of navigating the everyday life experiences. They know more than your centers do, I'm just saying. because they've probably navigated, or someone who's been there has navigated this before. But what I would poem about that withdrawn, does she have some depression? Is she struggling with something that could be clinically addressed by a wonderful psychiatrist like Dr. Anderson or your medical team, right? Or is the withdrawn maybe the apathy? Is it the loss? One of the things that I was thinking too that might be helpful is turning around the roles. So the other part of this was she used to do everything for her children, and she's unable to now. Now, if I couldn't do those things, I would feel a sense of loss. I'd be grieving that. This happens in every Huntington's family. It happens in every family where you have somebody that has a chronic debilitating illness. But we're talking about Huntington's now. You get role reversals. She was the caretaker. She was the one who gave birth to those children. She was the one who raised them, and her inability. So the thing is, maybe now acknowledging that there has to be a little bit of the role. You don't say how old the children are, but if it's possible for the children to engage her, and you could even like make little lists if the children are younger, right, and need some prompting, but if they're older, they stick it in on their phone, that they then become responsible for engaging her. Instead of all the energy coming of her caregiving, that one of the ways they can care for her and lift her up is by engaging her to not necessarily physical tasks. You don't mention if she needs that physical care or not, but in terms of familiar activities, things that you guys used to engage in as a family, that the initiation comes from you, comes from her loved ones, as opposed to the other. Because you are absolutely right, absolutely 100%, that every single one of us, and especially people who are experiencing loss with Huntington's disease, need a reason to get up in the morning. It's that simple, need a reason. And I think that's so insightful that you were able to see it that way. So I think one of the things is looking at how you can identify roles within your family where you're raising her up, where the initiative is coming from you on things that she used to take the initiative of in caring for your family. So I'm sure my colleagues have great suggestions too. I'll let them chime in.
Yeah, I would go back to my suggestion about doing something or a part of something that you used to like to do. So if you're not able to go out on the boat and go fishing because your balance is so bad that you'll fall in the water, do you enjoy sitting on the dock and watching the kids fish? Are you able to help direct the kids to do things around the house, even if you can't do all of them with them? So I think that's important. I definitely agree with the idea, Terry, of the structured things, structured lists. If there are other people in the family around who can help with things like that, I think those are all great interventions to help with that.